Welcome back to our final.
Hold on. I don't think it's live yet, is it?
It's live.
Okay, sorry.
Okay, it's the final presentation of the day. We are very excited to bring you 3 of our directors of CDKL5 Centers of Excellence, all very dedicated to CDKL5 research and delivering quality care to your children. So first we have Judy Weisenberg of WashU University and Rajaraman from UCLA. Eric Marsh will join after they're done with their talks for something that I'm very excited about. We'll be giving vignettes of real life situations and how to optimize existing epilepsy treatments. So with that, I'm going to hand it over to Judy, who will start her talk.
Thank you, Heidi. So it's been really fun listening in on all of these research initiatives and data collection, and I have taken a great deal of pleasure of being involved in them. But my original introduction to CDD is as a pediatric neurologist and epileptologist, which I have been doing as a clinician for epilepsy in general and CDD specifically for 10 years now. And really the goal of our discussion today is to talk about the things that are already available to us for epilepsy treatment. We know they are far from perfect in how well they work and their efficacy, as well as in our understanding of how to use them best in CDD. But our hope is to share a little bit of our experience and data where we can find it to help optimize the treatments that we have, because we do know that they definitely can help. As is always the case with pediatric epilepsy treatment, we will be discussing off-label use of treatments because most medication trials are still done in adults. So the simple approach to talking about the treatment of pediatric epilepsy in general would be to say, well, we have medications, we have special diets, and we have surgeries. But as I'm sure all of you know, it is far more complicated than just picking one of these treatments and working through it. When we start narrowing down our treatment approach to epilepsy through the lens of CDD, we start realizing all of the problems that we have. First of all, as I mentioned already, medications in general tend to have less pediatric data. CDD itself can vary significantly, even for one child at any one time, what types of seizures they have, how well their seizure control is, not to mention all of the other medical challenges they may be dealing with at any one time. When we talk specifically about the epilepsy, the closest data we have is infantile spasms West syndrome and Lennox-Gastaut syndrome, but truly that is a huge grab bag as it is. And CDD really is its own epilepsy phenomena. When you look for, as clinicians, when we look for evidence that's specific to CDD, we start realizing how limited the data is. Most of it is retrospective, meaning we've looked back over time and seen in a disorganized way different medications for variable lengths of time and how well they might have worked, for instance. And most of this data comes from smaller case series. And as you can imagine, if you want statistical significance, you need larger numbers to know better. This is a slide that I've used in many talks over many years. It shows that in the past less than a century, we've had a dramatic increase in the number of medications available. And this slide is already almost a decade old. And we continue to have new medications every year. And when it comes to looking at medications specifically, it's important to understand that each of them is unique. They can be roughly categorized by their mechanism of action, meaning are they what we call sodium channel blockers, or do they act on GABA, or do they act on calcium channels? These are all part of the electrical function of the brain. We also know that certain medications work better for certain seizure types. And we know that there are many different potential benefits and negative side effects So it's not a simple matter of a seizure medication. With that being said, we do not have the time to go through each medication, as there are over 20 that we are clinically using on a daily basis right now. Rather, I think it's very important to think about general principles when trialing medications. First of all, it's always best to go slowly and steadily with any new introduction of whether it's an increase, decrease, or starting a new medicine, not making more than one change at a time if possible. Something that often gets forgotten is interactions. When you add a medication to any other medications, there is a potential for interactions. One example that we can address a little bit more later when Dr. Raj speaks is Epidiolex, the FDA approved CBD formulation, we know affects levels of clobazam. And so introducing a medication may not just affect seizure control directly or side effects directly, but may secondarily affect seizure control by what it does to the other medication levels, or affect side effects by, again, what it's doing to other medication levels. Another thing that adds to the challenge is that seizures naturally fluctuate over time. And so the old adage, correlation is not causation, is so true here. If you make a change and immediately notice a difference, that still doesn't necessarily mean that one is the result of the other, because we know that seizures can be better some days, worse other days, for any of a variety of factors. And again, the importance of observing and making slow changes is so key to that. One thing that is very clear with CDD that has been observed by every clinician that I know who works with it is that there is often a honeymoon period. A new medication may result in a dramatic improvement for a period of time. And this is a wonderful phenomenon while it occurs, but unfortunately, it often is not permanent or long lasting. So that also can confuse the picture in determining what is the best medication regimen for your child. Of course, like every child, your child is not just one gene, and what works for one child may not work for another for any of a variety of reasons. In considering medications, side effects can actually be either good or bad things. If a medication, for instance, causes diarrhea in somebody who has constipation, this could be a secondary benefit, even though that's not the goal. On the other hand, some of our medications, the benzodiazepines, have a tendency to increase respiratory secretions, and that can be a challenge for a child who already has low tone and or is at risk for pneumonias. And so side effects have to be thought about very carefully through the particular challenges of any child. Ultimately, the most important thing to consider is, do you have a neurologist that works well with you, that listens to you, that hears your concerns, knows your child, and can work with you? I find that you need a plan A, a plan B, a plan C, a plan D, with that important caveat, all plans subject to change every time we're reassessing the next direction we take. Now, drilling down a little bit more onto medications, as I mentioned, we do not have, we could talk for days about each of the individual medications. I did briefly want to mention that every few years we do get a newer medication that might have a different mechanism of action than prior. Perampanel, which goes by the brand name Fycompa, is one that works differently than prior medications as far as the exact neurotransmitter that it acts on. Dr. Raj will speak about Epidiolex and CBD products. But these medications do work in different ways, and it is important to consider it when you are looking at different medications. Is this the same mechanism of action or similar to ones we've tried, or is it time to try just a completely different angle? there are also some medications that tend to get used less frequently, but may have a role. There is a newer medication called brivaracetam, which is essentially a newer generation levetiracetam. It has been billed as a medication that may have less behavioral side effects, less irritability. I think with experience, we will gain greater understanding on that. There's also a medication that I sometimes consider in my more challenging cases called methosuxamide, which is actually quite an old medicine, but sometimes can be very helpful. Unfortunately, that one can have some negative GI effects, nausea, and vomiting, which of course is already a challenge for our CDD patients. Another huge category of discussion is IVIG and steroids. When it comes to steroids, there is some pretty good data about its role in infantile spasms, and we'll hopefully have time to discuss that with some of our cases. But when we're no longer dealing with the first onset of spasms in an infantile period, it can become more challenging to determine whether they may have a role. IVIG is another treatment option that targets anti-inflammatory pathways, and there is definitely evidence in the general epilepsy world, as well as some work that's been done, particularly out of Cleveland Clinic, looking at how it may be beneficial to children with CDD. However, these medications also carry with them risks of side effects. Particularly IVIG is a burden of time as far as monthly infusions. And of course, I didn't even begin to talk about challenges with insurance on costs of all of these treatments. Again, the importance of a thoughtful relationship with your neurologist as you work through each of these treatment decisions is key. But the most important message that we're hoping to convey today is that there are a lot of options that can be used to benefit. Stepping back a bit, one of the questions that I think we always need to ask ourselves when we're trying to treat any medical problem is stopping seizures the goal? Of course, nobody wants their child to have seizures. I certainly don't want my patients to have seizures, but is 0 seizures our goal, or is the best quality of life our goal? Is optimizing development our goal? Is getting on fewer medications our goal? And I think all of us would agree that those are all definitely goals. We know that the more medications an individual is on, the higher the risk for side effects, the higher, frankly, the confusion if there is a problem as to what could be causing it. And it was interesting as Dr. Raj and Dr. Marsh and I were talking ahead of time, we all know that we were trained to keep working at it when you're in medical school, when you're in residency, and the inevitable trap is you can end up on 5 or more medications. Dr. Marsh mentions that he tries to get his patients to 2. I've found that to be a daunting task, especially when somebody comes to me already on 5 or more medications. But certainly for me, I do try to get my patients closer to 3 medications whenever possible. Weaning medications thoughtfully can be quite a challenge, but it is certainly something that needs to be considered at every visit, even when seizures aren't fully controlled. Ultimately, we are trying to minimize risks and maximize benefit, understanding that things are constantly changing. And with that, I will turn it over to Raj to talk some more about a few medication and the diet.
Hello, everyone. Can you see my screen?
Yes.
Okay, great. Thank you, Dr. Weisenberg. So I'll take over talking about CBD. So for everyone who's possibly new to epilepsy or CDKL5, a lot of my family say, you know, my friends say, oh, we should try CBD, or we should put your, we should try to have your kid on CBD. What are your thoughts? So I thought I'll take a step back and kind of talk about cannabis. So cannabis sativa, or is the marijuana plant. It's been used for medical issues for centuries. And now it's been very common use for multiple sclerosis, spasticity, post-chemotherapy nausea, pain. And there's been interest in studying for epilepsy for several decades. And we know in cannabis that there are over 500 compounds, 500 unique chemical compounds within cannabis. And two that are of interest is, one is THC, and that is the compound that gives you kind of the euphoric effect, the sensation of getting high. And the other one that's of interest is CBD. Now, CBD is not supposed to have that psychoactive euphoric effect, and it's supposed to be working on different kind of mechanisms. And CBD and epilepsy has been researched for several decades, but really came into national acclaim around 2012, 2013. So this is Charlotte Figi. She was a girl with Dravet syndrome. She lived in Colorado, and she would have about 300 seizures a month. And in 2012, her family, with a local dispensary, put her on a high CBD compound or high CBD product. And it worked very well for her. She went from 300 seizures a month to single digits. And they renamed her specific product Charlotte's Web. And she was featured in 2013 on CNN in a documentary called Weeds with Sanjay Gupta. And that caused this kind of national fervor and this international acclaim for trying to really research CBD more. And sadly, Charlotte Figi passed away this year at the age of 13. From what I read, it was a combination of pneumonia and seizures and other medical issues. But this really kind of brings up how severe epilepsy is and the importance of having discussions with families about what their thoughts and interests are, and the importance of research and kind of really looking at all our different compounds. So in 2018, Epidiolex was FDA approved in the US and is a plant-derived high CBD compound. It's FDA approved for Lennox-Gastaut syndrome and Dravet syndrome. And CDD kind of falls under the LGS umbrella. So some of my patients are able to obtain Epidiolex through insurance approval. It's approved for ages 2 and above. And some of the pearls that I try to tell my families that are important with CBD is to take with food. It's better absorbed on a full stomach. So I say take it after breakfast and after dinner. It does interact with medications. It increases clobazam levels. The brand name used to be Onfi, and it interacts with other anti-epileptics like felbamate. So families come and ask me, should we get off clobazam? Should we just be on Epidiolex? And I don't think that's necessarily true. We just have to measure clobazam levels. And if we start running into side effects, we say either back down on the clobazam, keep an eye on the Epidiolex. It's a constant process based on our levels. So you could be on multiple medications at the same time. We just have to be aware of interactions and measure levels. Common side effects is GI upset. It is within an oil. You can get some sedation with it, and you need to monitor liver enzymes. It is a chemical compound that you ingest, and it gets metabolized by the liver, like other medications. So we do have to watch closely the liver enzymes. So what evidence is there for CBD or Epidiolex with CDKL5? And there's not too much. So Dr. Davinsky at NYU did a publication, Epilepsy Behavior in 2018. And he had 20 kids with CDKL5, and they were put on Epidiolex in a compassionate use study. And seizures were reduced by 41% by week 12 and 60% by week 48, which is great. So if we had seizures from, let's say, 80 per month with CDKL5 and went down to about 40 or 50. So there was definite improvement that we saw with this very small retrospective cohort. Common side effects were diarrhea, sedation, and fatigue. And some of the caveats with the study that no one was seizure-free, which is very hard to do with CDKL5. They didn't really evaluate for infantile spasms. This was done after multiple medications already tried, and this is for older kids. It wasn't a blinded, randomized, placebo-controlled study. every patient within these 20 did get the CBD. So that's our kind of conversation about Epidiolex. And I'd like to talk about kind of rescue medications and how we can really try to optimize that. So a lot of these points come from deepconnections.net, the Developmental Epileptic Encephalopathy Project. It's an organization that looks at epileptic encephalopathies, which CDKL5 falls within. And they are doing webinars on rescue medications. So deepconnections.net is a great resource for families. So kind of a couple of things that we can look at is rescue medications for a continuous seizure. So I like to think of rescue meds for continuous seizures as well as cluster or repetitive seizures, where they're kind of shorter events throughout the day. And I'll go into the different options on the next slide. But for a rescue medication for continuous seizure, it really is kind of the threshold between the neurologist and the family about when to give a rescue med, because for every family it's a little bit different. Some people are comfortable with 5 minutes, some say even 7, 8, 10 minutes, because they know that those seizures kind of stop on their own. So at 5, 6, 7 minutes, those seizure resolves, and they don't necessarily have to give that rescue medication. And the common one that most of us use is Diastat or rectal diazepam, which is a good first-line FDA-approved rescue medication for a prolonged convulsive continuous seizure. The next rescue medications are for seizure clusters or repetitive seizures. So if your child has, let's say, 3 seizures in an hour, or had, let's say, 7 or 8 short seizures in a day, when they usually only have 1 or 2 seizures in a day, they don't want to reach for Diastat, which you use for the longer seizures. Is there a rescue medication for these kind of clusters? And I've often used clonazepam oral disintegrating tablet, clonazepam or Klonopin, where you put it in the cheek and it dissolves. And that can help to kind of break up these clusters. And there are now 2 FDA-approved ones that I'll discuss on the next slide. Giving rescue meds too often. So that is an issue where families say, you know, we're giving Diastat every day, or we're giving clonazepam or one of the rescue meds every day, or we're using it often. And that kind of tells me we should kind of take a look at the prophylactic medications or the maintenance medications and switch those up. Because if you're giving rescue meds too often, there's a sign that there's an issue going with the regular medications or the maintenance ones. So I'll say maybe the medications are not as efficacious as they used to be, or we need a higher dose, or we need to switch the meds. So looking back at the maintenance meds is a good thing to do at that point. And I ask families to keep track of when they give rescue meds, because if they're only doing it once or twice a month, and all of a sudden for 3 months in a row, they're doing it 10, 15 times, that's a warning that we got to change some of the daily meds. Seizure action plans are an important part of school and daycare. Every patient needs a seizure action plan. I recommend taking the time to kind of really figure out what the exact seizure action plan is for your child, and see if the school or the daycare are comfortable fulfilling that plan. Because some schools aren't comfortable giving rectal meds. Some nurses are equipped to do it, or they're Diastat trained, or sometimes they call 911 when it's not really necessary. So really setting a good seizure action plan with the schools is important. Keeping rescue meds in multiple locations. So I say keep on the top floor, the bottom floor, keep one in a backpack that's always with the child if you're going out. That way you're not really kind of scurrying and looking around for rescue meds. And always try to time the seizures. I know it's super stressful when there's a seizure going on, but if you can time it, that kind of gives you a better idea about how long these seizures usually last and when to give a rescue med. Checking expiration dates. You know, if we're lucky enough that we're not have to use Diastat or these rescue meds, sometimes they expire. So I say in the beginning of the year in January, just check your rescue meds and make sure that they are up to date, because you don't prefer not to give expired meds. So let's talk about several rescue medications are available. So Diastat or rectal diazepam is the tried and true FDA approved medication for convulsive seizures, and you could use it off-label for other seizure types, but that's been on the market for a very long time. Clonazepam ODTs is what I discussed. You can dissolve them in the buccal mucosa or within the cheek pouch. So if someone has a cluster of seizures and they kind of get in between or alert in between these seizures, you could try one of the oral disintegrating tablets. I don't recommend doing it while you're having like a big seizure sometimes because you can choke on it, but you could do it in the cheek or when they get out of a seizure to try to break up those clusters. And it's a fairly cheap medication. It's very good for kind of those rescue or clusters. Now, 2 medications that are new, FDA approved, both for repetitive or cluster seizures. Valtoco is an intranasal diazepam, so the same Valium that's in Diastat, except this is an intranasal spray. That is FDA approved for ages 6 and above for seizure clusters, and families have always done intranasal diazepam or midazolam kind of off-label. You can do it for the continuous seizures and not necessarily for the cluster ones, but that's kind of off-label usage to see if it helps. And that Valtoco is for 6 and above, and Nasolam is intranasal midazolam or Versed, and that's for ages 12 and above. So when you're using for pediatric patients, especially younger ones, it's off-label, and you have to see if insurance will cover it. Sometimes they say you have to try Diastat first and see if that works. So it could be a struggle with insurance companies to get these newer products approved for your younger kids. And it's actually a lot easier with a nasal spray, and it doesn't have that kind of social stigma with Diastat when giving it rectal med. And schools and nursing daycares are more comfortable doing these nasal sprays. So those are the rescue medications. The next thing I would like to talk about is the ketogenic diet, which is been used for epilepsy now for over 100 years. It started in the 1920s. And it is a high fat, low carb, very low carb, adequate protein diet, which has been shown even in randomized controlled trials to improve seizure control. And there are very different kind of options available. So ketogenic diet is often used as an umbrella term, but talking to your ketogenic diet team will try to figure out which diet is the best for your child. And a great source is the Charlie Foundation for ketogenic therapies, and they really are one of the pioneers with the keto diet. I recommend going to their website. So classic keto is 90% fat, 6% protein, and 4% carb. This is the highest kind of classic keto ratio diet. It's often used, it's actually easiest with patients who have a G-tube because there are keto-cal formulas and ketogenic specific formulas that you can get really high fat ratio that might not be as easy if you're going by mouth feeds. The modified Atkins diets, it gives a little more liberal ratio in terms of fats to protein and carbs. So that's 65% fat, 30% protein, and 5% carb. And this is often used for my older kids, and especially kids who can take food by mouth. And that gives them a little more liberal decision making with what kind of meals they want to have. And then another option is the low glycemic index, which is 60% fat, 30% protein, and 10% carbs. And there are even other ones called like the MCT diet and other options. So finding the diet that could be best for you is definitely available. So what evidence do we have for ketogenic diet and CDKL5? So this goes from Dr. Leonard's study from Epilepsy in 2017, and this is based on the family reported database, the ICDD. And in that database, we had 104 patients with CDKL5 who tried keto. And out of those 104, about half of them said they didn't see any changes. They didn't think it helped with their seizures. But then out of the 69, out of the 104, so the other 50% who said they saw improvement, 61 or 69, 88% reported improvement. Some kids reported worsening, so they did see a change, but it was in the opposite direction. And then 33% of those who were on the diet came off of it after a time because they said it wasn't as effective as it used to be. So reasons to discontinue, it wasn't helpful, it ran into side effects, worsening seizure activity, or they had difficulty in diet administration. And also, this is not a randomized trial for keto. This is families kind of reporting their experience with keto. So specifically for CDKL5, we don't have this randomized trial where we have a family on keto and they go back to a regular diet, or they were on a regular diet and went to keto and cross over to really try to randomize and see going prospectively how keto is for CDKL5. And I think that's a a strong research opportunity. So the ketogenic diet is a good option outside of medications. I feel like we don't often try it early enough. In the publication from 2017, the kids who were put on keto were having seizures for 3 to 4 years. And as we know, as you try more medications and as time goes on, kids become more and more intractable. So I think there is a vehicle in order to do keto early. You need constant supervision with a dietitian and neurologist. A lot of people in kind of mainstream and social media try to do keto for weight loss and other kind of energy sources. But especially with children, pediatric, you want to make sure that you're getting your daily vitamins, your daily metabolic need and natural supplements. So I always recommend doing it under constant supervision with a dietitian, neurologist. We often admit people when we initiate the ketogenic diet, especially the classic keto. So working with your team is important. And breaking the diet is kind of like skipping doses. If you're eating too many carbs and you're not ketotic anymore, you're not going to see the effect of the diet, and it's almost like skipping your dose. So before doing the ketogenic diet, where our patients see the dietitian and the nurse practitioners who are involved with keto, so we make sure everyone's on board and you're ready to go to that next step for keto. I think that is my last slide. I will hand it off back to Dr. Weisenberg.
Thank you, Raj. Oh, I didn't mean for that to happen. As was alluded to, in general, in the world of epilepsy treatment, if medications are not working, then that is when it is generally time to be considering alternative treatments, be it diets or surgeries. When it comes to surgeries, as best we can tell, the sort of surgeries that people tend to think of when they think of a surgery, like a focal resection, is not likely to be beneficial in CDD. However, there are surgical options, and these include the vagal nerve stimulator. The most important thing to understand about a vagal nerve stimulator is that its role really is for palliation. It is not expected, though of course nobody would complain, to result in complete seizure freedom. It really is like a medication. It is a device that gets implanted usually in the left upper chest, under the skin, and there are 2 incisions that are made, one on the left side of the neck and the other a small incision on the left upper chest, where the device is implanted subcutaneously under the skin, and then there is a wire that wraps around the vagal nerve, which is a large nerve that connects out from the brain. What we do know in general about the vagal nerve stimulator is that it can take up to 18 months in general to see the full benefit. It definitely can result in reduction in total number of seizures. There's also some evidence that it may improve mood. There's been some studies in people with depression that shows that they may actually have an improved mood with it. Side effects most commonly include hoarseness or a sensation in the throat. With the newer and newer models, there's a lot more fine tuning that can be done with the settings. There are now options that allow you to have a heart rate sensing response. So if there's an abrupt change in heart rate, which may be a clue for a seizure, you can set certain parameters so that it sends a stronger impulse on top of the baseline continuous impulse that it's programmed to do. There are numerous adjustments that can be made, and fortunately now with some of the newer models, you can program it so that it makes set changes over a period of 10 weeks without having to return back to a clinic for readjustments. Of course, in the end, it is a device, and so at some point, even if it's providing benefit, the battery stimulator part does have to be replaced. Fortunately, the time to needing that is improving with the newer and newer models. One thing that particularly in the world of CDD, I think is often forgotten is that there is some evidence that the vagal nerve stimulator can worsen obstructive sleep apnea, likely related to its effect on upper airway tone. And when you're already struggling with lower muscle tone, it's very important to know prior to VNS placement if there is evidence of obstructive sleep apnea, and to continue to monitor for evidence of symptoms of obstructive sleep apnea. What data do we have specifically in CDD? Dr. Leonard, and I know Dr. Demarest was on this as well, published a case series of 38 individuals in epilepsy research in 2018. Out of 36 patients that they had follow-up, 25 reported improvement, but it's important to note that the median was 73 days. So unlike medications where we would expect to see some evidence of effect within a week or two, it took much longer. Overall, there was no report of change in total number of medications taken. 9 reported improvement in behavior and mood, but 3 individuals in this series also stopped the VNS early due to side effects. Again, this is a retrospective study, not a randomized controlled trial. Finally, as far as surgeries, there is something known as the Corpus Callosotomy. This is a surgery in which an incision is actually made in a thick bundle of nerves that cross between the 2 sides of the brain called the corpus callosum. And this picture is credits of Dr. Matt Smith, our neurosurgeon at St. Louis Children's Hospital. The options include either a complete or simply, anterior 2/3 callosotomy. What this surgery does is decrease the severity of seizures. Many children will have a brief or longer holiday either in the severity of their seizures, but the goal is not, though of course, again, we would not complain, but it is not expected that seizures would be eliminated by this procedure, but rather that the intensity and the duration of the seizures, particularly for seizures called tonic seizures, in which there's whole body stiffening, and we can often see effects on breathing. The hope is that these would instead be more of a focal seizure where maybe only one arm was extended and eyes going to one side, maybe for a shorter period of time. One of the big changes in the past few years is that this surgery can now also be done less invasively using laser. This does minimize some of the risks of surgery and the recovery period. But it is important to remember that even when it's being done with laser, it is still an invasive, something is still being done in the brain, an incision is still being done in the brain. Our center has been doing them for the past couple of years, and we do think that a laser option probably works as well as an open, but there's a lot of information that we do not have at this time. When we specifically look at corpus callosotomy in CDD, there is no actually published data to date, no case series. The closest data we have is in Lennox-Gastaut syndrome. But this is actually a project that I'm hoping to be able to work on some more in these next few years so that at least we can share the information on our own patients' experiences. And with that, I think we'll move on to talking about some more specific cases.
We have a few questions that came in that were relevant to your talks. Would you guys like to take, there's just 3 that I see. Take those and before getting started on the vignettes?
Sure.
Sure.
In relation to rescue medications, Dr. Rajaraman, can you describe the difference between continuous seizure versus going into status and how you make those decisions with giving those rescue treatments?
Sure. So status can be defined as often by the duration of the seizure. It depends on which classification you look at. Some of them say it's 5 minutes or longer. Others say 10, 15 minutes longer. But a continuous seizure that goes on for a very prolonged period of time is considered status epilepticus. So you can have a continuous seizure that goes, let's say a generalized tonic-clonic seizure that goes for 3 minutes and then stops. That's technically not really status epilepticus. I don't know if Judy and Eric want to add anything extra.
Well, of course, it can be difficult sometimes to tell with seizure types other than tonic-clonic what is continuous and what is not. Things that are helpful to look at is whether the child is responding when you're touching them or repositioning them. Do they seem like they're acting back to themselves in between? If, for instance, it's a cluster of tonic seizures, are they clearly having periods in between the seizure where they don't look like they're in it? But it can be very challenging at home on a day-to-day basis sometimes to sort out what is continuous versus cluster. And an important thing is to be talking with your neurologist about the different scenarios you're seeing, because of course they change over time, and to decide how to use your rescue medications at home.
So in the same vein, but related to a different therapy, how long, and again, be honest about whether this is a comfortable thing to answer or not. How long do you recommend a child be on the keto diet before you think about weaning off?
So at UCLA, we say try for at least 3 months of continuous keto to give it a good trial. We don't start keto unless you agree to kind of really try for at least 3 months. And some people don't even see benefits at 3 months, but they're doing okay with the diet and they feel comfortable doing it. And then we see benefit as time goes on. So for the most part, we say at least 3 months.
And that's exactly what I advise, is a trial of at least 3 months before deciding if it's helping or not, assuming there weren't any significant side effects.
And that's the same at Children's Hospital Philadelphia. We strongly encourage everyone to sign on for a 3-month trial. And I don't know if the other part of your question was, if you're having some response and you've been on it for 2 years, how long do you stay on? And that, I don't think anyone really knows the answer to, of what to do. And I think, like any medication, at some point you just have to try to lower things and see, if you start down and they have a significant increase in seizures, then the diet's still working for you. If you continue, if you go down and you don't see any change in the seizures, then maybe the diet's no longer working for you. So.
Yeah, I totally agree with Eric. I've had families saying, I've been on the diet several years. If we try to come down, I don't really know if it's helping. We start coming down on the ratio, and all of a sudden seizures start popping up, and we say go back up on the ratio.
Yeah.
Okay, I think we'll move on to the vignettes because Dr. Marsh has to go, and we would like to move through these as best we can. So the first one is a 16-month-old girl who is having epileptic spasms, body crunch with arms out, with hips arrhythmic EEG from 6 months onward, treated with ACTH with no response, started on vigabatrin with some reduction in spasms frequency. Topiramate was added with no response. Onfi was added with mild reduction in frequency. On vigabatrin, Onfi, and topiramate, and as events persisted, the child was started on keto diet at 13 months of age. By 16 months of age, the seizures stopped. Now the child is 20 months old and remains seizure-free. Would the panelists please discuss what to do during a so-called honeymoon period for those children who are lucky enough to have one, and what the plan of action would be for weaning or not weaning drugs?
Who wants to take this one first?
So I'll jump in first there.
Okay.
So yeah, so just the first note for people is that, not every child with CDD has a honeymoon period, that a good percent will have a honeymoon period, but the duration of the honeymoon period is unknown when it starts. Some kids will go a few months, some kids can go over a year without having seizures. So it's hard to know whether, if the seizures stop shortly thereafter, or as you ramp up, say in this case, the ketogenic diet, maybe it's not really a honeymoon period, maybe it's the ketogenic diet. But we're in this case where it says that it was like 4 months afterwards, is it the diet, is it the meds, or did they hit the honeymoon period? So personally, as Judy said at the beginning, I'm a big fan of trying to get people off of medication. So I would use the thought that maybe they're in a honeymoon period as a opportunity to try to at least get them off of one, if not two, of the 3 medications that they're still on, because it's unlikely that they're all being effective. So I would probably start off with the vigabatrin first because of its potential longer-term toxicity with vision. And then, it sounded like in that case, the topiramate wasn't doing much, so then the topiramate, and then seeing how they
Leave
did.
the room and close the door behind you. I'll be done in 20 minutes. Okay, close the door.
And the ketogenic diet and the and clobazam for a while, and then if the seizures start back up, then use that as a new baseline to make further changes from, and use the period of the honeymoon to kind of clean the slate a little bit, so that when, unfortunately, invariably when the seizures start back up, that you'd have a different, a cleaner slate in which you're going to try new medications with.
Yeah, I agree. I think during those periods, it's often a time to kind of look back and see which medication was started, probably the earliest or first, probably wasn't as effective. And if you've had a medication that's been kind of just lingering for like a year or plus, that's not really, we don't know if it's ever been effective. It's probably a good time to try to come off that one. So you can use that kind of period of seizure freedom for your benefit, to see if you could try to get off one of those older meds.
And I think the key points have already been said. The one thing I would mention, particularly with Onfi or clobazam, is that a really slow wean is needed because there is a risk of rebound seizures. And I'm sorry if I missed if that was already said. I had a little interruption.
That's okay.
But going slow with Onfi, I typically make a small change every couple of weeks with the goal to at least get to a lower dose, if not off.
I think just, I'm curious, both of your thoughts on this. If let's say the case was slightly different, the diet was added, and after 2 weeks, when on a 4-to-1 ratio, the child's seizures stopped. So maybe it's more causal, that you think really the diet was having a big impact. So then you still try to take off other medications, or the case seemed to set up that it was more of a honeymoon period because it was a real delay in response. But if there was an acute change and became seizure free, then would that change? Would you still try to take things off, or would you wait longer, or what would you do?
Depends on the family. If they want to just not rock the boat and leave everything the same and say, this is my first time seizure free, let's just leave everything alone. I would be fine with that as well.
Yeah, I tend not to rush into let's take things away if things are going well. So even if it does really look like the diet was making the change, I'd probably want to wait at least a month before talking about small, slow changes. And also, of course, whenever I start a wean, we always talk about if things seem to start to flare again, what is our plan? Are we going to go back up on something, or are we going to try something new?
Dr. Marsh, you mentioned vigabatrin, the peripheral vision issues. I really don't worry too much about that when starting vigabatrin with our kids. I just, when I send them to opto and looking for like electroretinograms and OCTs, that we just never really picked it up, especially with CDD when you already have kind of vision issues. So I don't know if you do a lot of counseling with that.
No, I agree completely with that. I think with CDD and a lot of these really other very early onset severe epilepsies, the vision issue is not as much of a concern. But the reason I brought it up is because if you were choosing to take something off,
Yeah.
and you have 3 options to which to take off, and one was the vigabatrin was started early, it's been on for a long time, there is that potential risk in the back of your head. Would that be a reason to take it off first?
Sure.
And of course, the combined sedation effect of multiple medications. And I do think vigabatrin can be pretty sedating.
Yeah. The MRI changes, the reversible hyperintensities that we have to counsel families to kind of keep an eye on with vigabatrin toxicity. I feel like I see that more often. So in terms of like if your child's too sedated or is kind of having hyperkinetic movements, is that kind of vigabatrin toxicity? That's something I worry about if they've been on it for a long period of time. And so that could be a good time to maybe think about coming off it.
Yeah, no, I agree. And that's, the vigabatrin with its more, at least by label, more significant toxicities, it's something would that push you to take that one off first if you have a bunch of other potential medications on? But, it also depends when it came on, how effective you think it was, and how sedated, all the different variables that come into play when you make your decisions. These are not easy decisions to make. And of course, the family's view of what they thought was effective and, also weighs in, I think, all of our decisions. Yeah.
Wonderful. So you think it's okay if I hit you with another one?
Sure.
All right. This time we have a 6-year-old girl with past infantile spasms, a brief honeymoon period, seizures restarted by 18 months, and has tonic stiffening spells, body crunch spells, epileptic spasms, and drop seizures, usually head nods, but whole body can lose tone. Has failed to pyramate, Zonegran, phenobarbital, vigabatrin, Depakote, currently on Onfi, Zonegran, and the keto diet. Seizures are multiple times per day, but always brief. Though some cluster, no status epilepticus. Can sit unsupported, kneel, but not walk. Can reach and hit what she wants, laughs and smiles, and responds to her name. Now, would the clinicians please discuss next and newer treatments for an intractable child who has not been through a ton of meds yet? Eric, you look like you want to start.
Okay, so this child has been on a variety of medications, but there are still a number of medications that could be tried. Both Raj and Judy mentioned a couple of different options in their very nice talk. With this multiple types of seizures, depending on what the EEG showed, this child would potentially be in that grab bag of Lennox-Gastaut syndrome. So the indication for, say, Epidiolex would be a possibility. So Epidiolex would be something that I would consider starting. Briviact is a newer medication. I don't remember if this child has been on Keppra or not, but that's another new medication. So I think, as the child is doing well, but still continuing to have seizures, though they're brief, I would try to make further adjustments. I would go slowly and do one thing at a time, but I would try to make further adjustments without, with being very careful about trying not to sedate or do anything that would reduce the how functionally she's doing very well. So I would go slowly and do one thing at a time. But I think, and there'd be a number of different medications to try. And as Raj said, a lot of families are coming to me asking about Epidiolex. And since you probably would fit the clinical description of LGS, and you'd be able to get it from an insurance perspective, it would be something that I would potentially consider trying sooner rather than later.
Yeah, so I think that was one of the key points, is that this is a child who's a good candidate if we're still looking at medications for Epidiolex. Different families are more or less comfortable with felbamate, which I did not put much time into. It is frankly an older medicine at this point, but it has been one that I found to be in general very effective. But of course, there has to be a serious discussion about liver and bone marrow risks and the need for frequent lab monitoring. So that is something that I think it is one of our less sedating medications, but you do have to be careful about interactions that could also be discussed at this point. And of course, with the goal of weaning some of the other medications if you're introducing a new one.
Yeah, I'm happy Judy brought up felbamate. I was thinking that's a good option. In terms of kind of hepatotoxicity, aplastic anemia, those are things you do lab work to check and keep an eye on. But it's often very rare in the pediatric population. It's a very effective medication. So it's one that I use early if needed, and it's a really good medication. You just have to do lab monitoring. And in terms of medications, we try to look for different mechanisms to kind of attack seizures from different points. So felbamate and Epidiolex and perampanel, I think, have different kind of mechanisms than the ones she's been on. So she still has med options that I think are still reasonable.
Would either of you potentially just say, well, she's doing well, the seizures are brief, they're not that, they're daily, but they're brief and short and developmentally doing well, that you would just stay where it is without making any changes? Or would you definitely try to get to even in better state?
Is the trajectory that she's kind of leveled off into the same pattern despite multiple changes already?
Yeah, let's say so. Let's say she's been, it's kind of stable for a year now at this pattern.
Yeah.
Or,
and I would, yeah. Sometimes one of our plans is let's hold the course for now, if that's something that is the family's preference. They are tired of adjusting things up and down without seeing any clear benefit. And we go through the pros and cons of each of those options. It's still a good idea to have a plan if things clearly flare or if development is no longer doing as well. But I think one of the options can be, let's do nothing for a while. Not doing nothing, but maintaining status quo. Do you agree, Raj?
Yeah, I think it's definitely the right possibility for him.
Yeah, I mean, and the right to come off of something, which is on 3 medications in the diet. Would you start down on something and see if you stay at this decent level, and then if it flares, have your plan to then start something new, and be creative of using this time where things are not terrible to potentially try to come off or add something new as do both at the same time.
Mm-hmm.
Yeah, it could be a good time to replace with something new. A lot of times, if I add a new medication, I go up on that one first until we're in the therapeutic range, and then start coming off one of the older ones. So there's a point where you're on an additional medication, and then when you're coming off the older one, you start noticing seizures start increasing. So then you kind of in a rock and a hard place in terms of what do you do with that new medication. So it's a bit of a balancing act to see what if the seizures worsen and what the family wants to do next too.
Yeah, it is. It really is a conversation to have between you and the family about what they're most comfortable with and where they want to be at. As I think Dr. Weisenberg said in one of her original slides, the importance of that conversation, being comfortable with the relationship, and the goal of, in this case, maybe she's at the goal, and like to have that conversation. What is the ultimate goal? Yeah. You want to do another one there?
On to another one. I listen to this and I think about the practicing medicine and the science and the art of it,
It's
and
very much an
learning
art.
as we go. This next one is a 10-year-old boy with continuous seizures since age 4. The main seizure type has always been body stiffening with arms raised, but has also had full body jerking spells, atonic seizures, and laughing seizures. Has multiple brief daily seizures, has failed more than 10 medications and the keto diet. Now on Onfi, valproate, Banzel, lacosamine, and Epidiolex. Does not sit unsupported, but does smile and react to environment. Sleeps a lot during the day, however.
Shall I start this one?
Sure.
Go ahead.
So first of all, the interactions in that med list, the potential there. Epidiolex raises the Onfi level. Epidiolex probably affects rufinamide level. Depakote and rufinamide, Depakote and Onfi. It is not surprising that that child is sedated. It's a real pharmacologic quagmire right there. So that's one issue. And then the other thing is, at this point, especially with tonic seizures, and it sounds like, is that vignette alluding to some tonic-clonic seizures as well? This is a child where considering a surgical option, whether it's VNS or corpus callosotomy, it's definitely time to have that conversation. Certainly, we've not tried all of the medications out there, but to throw another medicine into that list is asking for even more interactions. And so in this case, it appears that the seizure burden is still very high. Moving forward with VNS or corpus callosotomy with the hope that that will improve things enough that you can comfortably start to wean, but may need to wean anyway, something, and checking levels can help there. This is the time to be talking about those options.
Yeah, I think weaning medications, it really depends on how severe the seizure burden is daily. But if the patient's sleeping through most of the day and not interacting at all, or not even having much wakefulness, I think it could be a time to start weaning because of the interactions. And then vagal nerve stimulator is definitely a good option.
Yeah, I agree. I think they're right. Judy said it. That's a medication quagmire with everything that potentially interacts with each other. So trying to clean up those meds, and I would guess that when you started to adjust things in that child, there would be probably not a big change in their seizures, like that it's unclear, what's doing what, so you can come off. And then looking at other options, offering the family the VNS as an option or callosotomy as an option, I think would be a very reasonable thing to do as well. So, but I think I would first try to get things off and see if he was awake and happier and that the seizures weren't as bothersome, and then make a next decision once try to get things off, if possible. If they start down on any one thing and seizures really took off, then you're kind of stuck, and then you say, oh, now I know why this child got to that state. It's because everything seems to flare when you make any changes. Which brings, I have a question for the two of you. One of the things I tell families in this situation when you try to come down on things is that expect a little flare, like expect a few days of a flare, and then if you don't do anything, it should settle back down. Do you guys think that's true? Do you guys something that you've seen?
Absolutely, and that's why I try not to make a change more than once a week, and ideally every 2 weeks. Somewhat depending on the half-life of the medication, but I think you need at least a week just to know if something's a consistent trend versus a flash in the pan, a good day or a bad day.
Yeah, I think just a slow and steady wean, and if the family is comfortable to just keep an eye on things at home and things like clobazam, where like you wean off like over 3-4 months, or take the time, and hopefully things don't rev up to the point where the patient has to go to the hospital to get evaluated, and then you get in trouble. But if you see a kind of spike in seizures, and hopefully just hold the course.
Yeah, I definitely that if you start to go down, you'll often get a few bad days, which, if you just wait it out, then they settle back down to where they are, which allows you to keep on going down. But it's so, parent calls and says she's having, instead of 3 a day is having 8 a day. The knee jerk of going back up or making a change is hard to, when you're on the phone with a parent who's concerned, it's hard to push through, but it's something that I always try to tell myself, no, push through. And I often fail myself and don't do it, but I try.
Yeah, if the family feels like it's been going on for like days and days, and like, oh, we have to come to the hospital, and if they're super stressed, then yeah, I think sometimes going back to the regular dose is definitely a good option too.
Okay, we are halfway through these guys, and I know, Eric, if you need to jump off, I'm sure we can have Dr. Rajaraman and Dr. Weisenberg take over with the last few. So we'll just press through the best we can. Next vignette here is a 4-month-old girl, no previous seizures, but low tone. Poor head lag developed events of abdominal crunches and arms extend for a few seconds at a time, but occur in clusters coming in and out of sleep. Tone and level of activity worsened with onset of events. EEG shows hypsarrhythmia. Plan is to, and if the specialist could discuss infantile spasm treatment in CDD in general.
Raj, do you want to start or do you want me to?
Sure, I could start. So I'm sure we all probably will have maybe different ideas about how to treat kind of first line for infantile spasms. At UCLA, we do combination therapy. So we do prednisolone and vigabatrin combo, high dose pred for 2 weeks. And then if we see the prednisolone is not working, then we switch to ACTH combination therapy with vigabatrin. And that's kind of based on some of the data out of Europe. And we just started doing that within the last few years. We used to always do first line prednisolone and then switch to ACTH if it's not helping. With the caveat with PS, we do vigabatrin first. But with CDKL5, we'll probably do combination prednisolone and vigabatrin first and see how things go for 2 weeks.
Yeah, actually, that's very similar to what I do at this point. I almost never would consider ACTH first line. I would use high dose prednisone first with a quick reflex to bring vigabatrin in. Early treatment still is our best option, at least to get us better developmental outcomes overall. And of course, there's often a lag to even identifying spasms.
Yeah, we actually are been a little slower on the combination therapy at the get-go, waiting to see kind of where some of this data will fall out. And I think one of the challenges is what we assume this, we know this kid has CDD, but when did you find out that it had CDD? If you just low tone doing well, you're gonna, the normal view is kind of ACTH, high dose pred, combination therapy, because if you can treat the hypsarrhythmia and the spasms, you expect to have a better outcome. And but at a gene specific response, we actually don't know that to be the case. And that does the underlying etiology trump any, treatment related response. And that's something that we need to learn about all these conditions, and definitely about CDD. So if you didn't know, I think we would definitely go more aggressive with high dose pred and then switch to ACTH. If did know, I might just start with pred and see how it does, then then go to vigabatrin or something else afterwards, with the risk benefit of everything coming into play here. But
yeah, I think less and less we're using ACTH in general. And I will say, with genetic testing being available, We're getting panels sent off if they had not already been being evaluated for their development or tone before presentation. I have had genetic diagnoses come back during my prednisone trials now because of the more available clinical testing. You're correct. Yeah, we absolutely don't have specific data on outcomes with CDD. But one thing that I think one of your other vignettes alludes to is that a lot of times our CDD patients had something else that didn't look quite as obvious, like spasm first. And then when the spasms do emerge, there's a delay in recognition that confuses the picture too.
And even with the first-line therapies for spasms, it's very center specific. So some centers don't do high prednisone, and they only do ACTH. And if that doesn't work, they go to vigabatrin. So I think, although there's definitely more data for infantile spasms in general than CDKL5 specific, each center has very different thoughts about which way to do it first line. And then Heidi brought up that the EEG showed hips arrhythmia on the background. And I'm curious what you two think. It doesn't really change my kind of approach if you have hips or not in the beginning. In terms of treatment for the spasms, we will just do our normal first line treatments. And sometimes you don't see hips until later on in the EEG. And if you're lucky enough to get on the first couple of days, you won't have hips and just have spasms. As time goes on, sometimes you'll have like more hips and less spasms, and it kind of changes. So it really depends on the time when you get those EEGs, but first line, it doesn't really change my management.
So yeah, I mean, the clinical is so important here. In this scenario, we have a child who's, I believe the child is either plateauing or regressing developmentally. That gives you a clue of the encephalopathy that goes with the spasm. And so that's your clue to be aggressive. And of course, the other thing is that there can be disagreement on what is full hips arrhythmia versus it's somewhat abnormal. And that can lead to a variation in opinion on treatment. But overall, if I've got a child who clearly is having spasms and has a developmental plateau or regression, then I would go with first line treatments.
Yeah, I totally agree. And, but CDD, not a lot of kids will have spasms, epileptic spasms, but not necessarily develop hypsarrhythmia. And so, just to go with the more aggressive high dose PRED or combination therapy or not. And, there's, as Raj said, it's center specific, it's physician specific. Unfortunately, we don't have great data on this. And this goes back to Dr. Demaros's previous talk about collecting natural history and longitudinal data so that we can even, regardless of clinical trials that are hopefully and will be coming forward, having better information by which we can make more educated decisions about what is the right thing to do when you have a 4-month-old with CDD who doesn't have HIPSI, is, putting the parent through high dose steroids and all the things that go with it. Is it worthwhile? Is it going to get a better outcome? And that would be something that we really need to know so that we can all make better decisions. But right now we're all, in some ways, it's the art that you mentioned there, Heidi, that it's the art of treating that we all are trying to do as well.
Yeah, and of course, Dr. Olson is trying to look at spasms treatment specifically. And what I found when I went back and looked formally at the patients at our center was that almost universally there was a lag in identification of spasms, which further confused the picture.
All right, guys, I'm going to actually have to step out, but thank you very much for having me and having been part of this discussion, and excellent talk, both of you. So thank you, and everyone have a good rest of your day.
Thank
Thank
you,
you, Eric.
Thank you.
Well, thank you for staying with us. We are running long because all of the sessions that we had today were very productive. So we have a couple more. The next one is a 9-year-old girl with daily events of body stiffening and extremities jerking. These typically last about 20 seconds. These events can occur every few minutes and go on for up to 2 hours, or rarely, the extremity jerking can last for over 5 minutes, but it eventually resolves. The longer ones occur weekly. The clusters can be multiple times per week. The child is on the ketogenic diet, vigabatrin, and Onfi. If you wouldn't mind, could we discuss rescue med treatment?
Sure. Would you like to go first?
Well, you talked about rescue
Sure,
meds in the
I will.
talk, but
Sure.
I don't, this is another one where there's not one right answer for sure.
Yeah. I'm happy to go first.
Okay.
So the continuous seizures versus kind of the repetitive ones. I think her age was less. Her age was under 6, I think it was, correct?
No, I think she was older.
I will double check. It is a 9-year-old girl.
9-year-old. Okay. So for a 9-year-old, for the repetitive clusters, you could try clonazepam ODT, which you won't have an insurance issue obtaining. It will be kind of based on the family's feeling about how often these clusters occur, and you could try clonazepam ODT in the cheek to see if that breaks up the clusters and slow down the repetitive seizures. At age 9, she could be a candidate for one of the intranasal ones who's FDA approved for that. And you could try to obtain either, just it's really based on insurance, to see if that slows down the repetitive clusters. But if you feel like you're giving either the clonazepam or the nasal spray daily, then I think we have to go back on the drawing board about changing one of those, either Onfi or vigabatrin or the third medication. See if you can reduce the number of clusters. With some of the longer ones where she's having like up to 5 minutes, if they do resolve on their own around 5 minutes, I don't know if it's necessary to really chase all those with a rescue medication if you know they're going to end around 4 or 5 minutes. And you can also do either a diastase or the nasal spray for those ones. But if you feel like, again, if you're giving that a lot, we have to work on one of the maintenance meds. So it's a combination of kind of comfortability with what the family feels about giving the meds at home. If this is like a sudden change where she used to only have like 1 cluster a week and now she's doing daily clusters, we kind of have to figure things out.
Yeah. So yeah, I agree with the prolonged seizures about not necessarily using a rescue medication if they're resolving 5 minutes or so. 2-hour clusters do not sound pleasant at all. And clearly looking at the trend is important, but probably, at least for the short term, is something that you would want to use a rescue medication. Most likely clonazepam would work well for that.
Yeah. I think that's clonazepam ODT has been pretty tried and true in terms of trying to break up the clusters. It's only been recent that we've had the nasal sprays available. We've been doing off-label kind of intranasal midazolam, where you can kind of prescribe and put the pieces together. And families have been doing that for years. But in terms of FDA approval, that's only been kind of recent.
I guess the one other piece for discussion is that some children do seem to react differently to some of the benzodiazepines. And so there are some families who ultimately find for clusters that oral lorazepam or diazepam actually does work better for their child. There is some variation in how quickly they work and how long they last, but depending on what you're treating in a cluster, there are other options that are just a little less standard that Dr. Raj didn't get to in his talk. So always more options.
Yeah.
Thank you both. We have one more vignette, and then I think we have a few questions. So if you don't mind, we might come back and ask some of the live questions that are coming in that have relevant to both the vignettes and to your talk that you started with.
Sure.
All right, here we go. Another boy, 2 months old, with new onset of subtle body stiffening and left arm jerking for 10 to 20 seconds, happening a few times per day on transition from sleep. Started on phenobarbital and seizures persist. He is eating and drinking well. Can we discuss as a panel early seizure treatment for pre-spasms and surveillance for infantile spasms?
Shall I start this one? So especially when you're dealing with the very early childhood, the data is really not there. Doing studies in neonates and young infants is really not there. And that includes for CDD, we've got retrospective data. A lot of times infants do end up on phenobarbital because it's been around for over a century and as best we can tell is reasonably safe. More and more we have been using levetiracetam in the NICU, which is the generic name for the brand Keppra. And as far as safety, it seems to be a reasonable option, as does topiramate or Topamax. There is some data about using those in infants. You actually do need to dose differently because younger children metabolize, actually their kidneys clear things faster. So sometimes you have to dose more frequently at lower doses to get the same effects. But the key thing also that's being brought up by this case is, are the seizures changing and are they actually spasms? Now, obviously no family is going to want to bring their child in for a weekly EEG, but a close monitoring of what's going on with their mental status, their level of alertness, their playfulness, head control may give you clues in addition to what the seizures look like themselves, that it's time to repeat an EEG to make sure we're not missing spasms. I think those are some of the key points I thought of from that case.
Yeah, I think the phenobarb has been around forever and it's a great medication, especially for kind of neonate infantile seizures. But if you're running into sedation or any kind of things that could cloud whether development is slowing down, I think it'll be a good time to maybe switch that to a medication that might not have as much sedation. And I would probably bring in the EEG just to see, bring the patient in for EEG to see if these are definitely not spasms or spasms, or they're kind of transitioning to them, because the patient's kind of around that age where, especially with CDKL5, where you can get early infantile spasms, just to make sure we're treating the right thing.
Wonderful. So I think you have some questions coming in from YouTube and maybe Facebook. I haven't been monitoring all the sites, but Amanda and Karen are here.
Yeah.
I see. That.
Go ahead.
Go ahead.
I was going to say, do you want me to ask a question from YouTube, from the YouTube?
Sure, go
chat?
ahead.
Okay, so we have a question that says, how long do you recommend a child be on keto diet before you think about weaning off?
I think we discussed this one about, we say at least
Oh,
3
did you already
months.
ask that one, Heidi?
Yeah.
Yeah, Karen,
I'm
why
Okay,
don't you?
I was gonna say, is that the same
No,
question?
Okay, Amanda,
Carolyn,
ask
so-
the first one.
Yeah. Okay.
I'm so sorry.
That's okay.
So back to the CC, the colostomy talk. Do you think there's enough research in CDD to recommend this?
So honestly, with every treatment we offer, there's probably not enough data to say absolutely you should or should not do something. I think from our general epilepsy experience, there is clearly evidence that it can improve seizure severity. And then really it comes down to a careful discussion with your neurologist, the potential surgeon, about what the goals are. If you have a child who is having numerous tonic seizures an hour and has tried so many medications, including felbamate, including Epidiolex, particularly if they're walking and falling. Corpus callosotomy can make a tremendous improvement in quality of life. And hopefully, without revealing identities, I can say that I have a couple patients that I personally follow who I think would both say that it was clearly the right decision for them. But this was one of my points also. What is one child's experience is not necessarily going to be the same for another. It's always about what are the options, what are the goals, and weighing it. And I do feel that in some cases it is the right thing for sure.
Yeah, I agree. I think callosotomies, there's always a place for callosotomy, especially if it's been known to reduce drop attacks and drop seizures. And as long as we kind of go in knowing that seizure freedom is definitely not the major goal, but trying to have a reduction and kind of definitely reduce the amount of seizures, I think callosotomy is definitely a good option.
Okay, terrific. Another question pertains to diagnosis. And this person is wondering if you are still seeing patients misdiagnosed with Sandifer syndrome as they get beyond the toddler age. I guess kind of, are we picking these patients up early enough so they're not misdiagnosed with non-epilepsy DXs that kind of probably delay treatment?
I feel like we still in the community of infantile spasms often there are delayed presentation, whether it's Sandifer syndrome or we say, oh, that's just normal baby movements, or we say, oh, and it could be reflux or sleep movements. I think there's still definitely a delay to presentation, and I think kind of education about what they look like and pediatricians kind of discussing kind of movements. And if there's any kind of concern, I always say videotape it, have the pediatrician send me the videos, and kind of just keep a close eye for any kind of abnormal movements, because I think doing an EEG or just seeing like a cell phone video can save a lot of time and heartache. I don't know how you feel, Dr. Weisenberg. Yeah.
I guess the question was asking into toddlerhood. I definitely have seen delays during the infant year, the first year of life. I don't think I've seen it much past age 2, but that initial recognition, yes, unfortunately, there still is a delay. I think overall, diagnosis of underlying cause, genetic diagnosis, ultimately we're doing much better, in part because of technology availability, but that initial identification that something may be wrong, either developmentally or actual seizures, in that, especially the first 6 months, there is still some delay.
Yeah, I think toddlerhood, you would probably start seeing other developmental issues, delay in sitting and walking, and that would be other clues than just possible Sandifer syndrome.
Okay. There's one question that it remains from yesterday. Tim shared some new research updates. And this parent is asking about, when they asked about the keto diet in relation to seeing high cholesterol in CDKL5 infants and kids before they start the keto diet. We had been talking about mitochondrial function related to CDKL5 dysfunction. And he said, oh, that's a good one you should save and ask the clinicians who are.
Great.
This is now coming back.
All right. Thanks a lot, Tim.
I remember that question from yesterday. I asked my keto team, and that's not something that we've seen too much pre-keto with our CDKL5 kids. But I think that's, I think 1 or 2 families said that yesterday. So I'm gonna have to kind of go back and really check the keto database to see what cholesterol levels were for our pre-keto kids with CDKL5 and see if that's really a trend to it.
I don't think
can-
I've known, oh, sorry, go ahead.
Well, I'll let you finish, and then I was going to talk about post recording questions and an opportunity to chime in.
Okay. Yeah, I was going to say, I mean, there were kind of two questions in there. One was whether we're noticing a trend with cholesterol, which off the top of my head, I hadn't noticed, though actually I've had some other observations about hemoglobin that I've been meaning to talk to my colleagues about. But the mitochondrial question, I think, is a very complicated one that, yeah, I don't have a good answer to. But I think we've all wondered about that.
So I think it's fair to say we're getting some really fantastic questions from our families, and that there'll be an opportunity to ask additional questions as we post these, because not everyone is able to watch live, and that we can get more answers out as we get questions in, and they'll be available on cdkl5.com after we've completed this. I know there's a break coming up, and then there'll be the tribute. Karen and Amanda, you have any additional things you want to add?
So
I
I just want to thank you guys. I hope I think this was a great panel. I hope that everyone watching out there has a little bit of a little less apprehension about maybe having these types of discussions with their providers if they're especially new to the diagnosis.
Okay. Thank you for the opportunity.
Yeah, we will be sure to work with this team to get questions answered that you guys have coming up. And we have a little bit of a lag before we view our tribute video here at 7 p.m. Eastern. So in that time, I have actually posted to our Facebook page an update from Ovid Pharmaceuticals on the TAC 935 trial. Phase 2 has been complete, and there's probably a 15 or 20 minute video from their clinical director updating us on what's going on with the trial. So pop on over to Facebook and check that out. And we will come back, and we will not YouTube live the tribute. That's not really a nice way to go back and forth with each other, but we will Facebook live the tribute, and we will actually be dropping the Zoom link into our event, our Facebook event. So you guys can actually come and join us at Zoom during the tribute. Aside from that, I think, let's see, I don't think I've forgotten anything. Karen, have I?
I'm just going to add to just remember what I said in the welcome and opening address, that, we did these few live sessions, but it doesn't end here. Continue to watch and know that we're going to be releasing more talks and sessions for weeks to come. So
yeah, and thank you guys for your patience. We're all learning. We're all learning how to work things out in Zoom and in the virtual world. There's nothing like being together, and the next time we can be together, we'll definitely that's where we'll be. So with that said, I think Heidi, anything I'm forgetting from your end?
I don't think so. I think we can sign off and thank Dr. Raj and Dr. Weisenberg for everything that they've done to help us put this together. It was fantastic.
Thank you.
Thank you.
Thank you, everyone.
Thank you. Bye-bye.
Take care. Bye-bye.
Take care, everyone. Thank you.